How to collaborate with a dietitian. Tips for working with RDs as an SLP. Do you know how to collaborate with the dietitian at your facility? Is the RD your bestie or more like a total stranger? SLPs and RDs collaborations are important. We can have very powerful positive outcomes for patients when we work together. It has been well established that patient swallowing ability and nutritional status go hand in hand. Since swallowing and nutrition are so intertwined, establishing a positive, collaborative relationship with your facility's registered dietitian nutritionist, an RDN, is incredibly important to ensure that your patients have the best possible outcomes. Today, I'll be talking about exactly what you can do to collaborate with the RD in your life and how you both can achieve better outcomes for your patients. Let's dive in. I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education. Go out of your way to get to know the RD or RDs on staff in your building. You'll need to get to know a lot of interprofessional staff at any job you take, but it's important to go out of your way to meet the RD or RDs if there's more than one at your facility and introduce yourself. First, I want to distinguish between the registered dietitian, RD, and the dietary manager. In some facilities, they may be the same person, and in some cases, they are not. The dietary manager might do the purchasing, manage the staff, and ensure the patient's diet orders are written correctly. This is very different from the registered dietitian. I know I've unintentionally mistaken the two before. So anyways, once you know who is who, don't just stop at introducing yourself. Swap contact numbers, whether that's a pager, an office phone, Vocera, or your cell phone. You'll need their number, trust me. Let them know which units you serve if you're in a hospital setting. Some hospitals or larger facilities might have different RDs serving different units, so that's helpful to know as well. If you go in to see a patient and the RD is already in the room, ask if it's okay if you can join in. So much wonderful information can be collected from the RD's assessment or educational sessions. SLPs need to understand things like dietary restrictions, goals, and tube feeding schedules when working with a patient with dysphagia. Also, make it a point to read their notes for shared patients and call the RD whenever you make a recommendation around their diet. I hope this video is satisfying your appetite for information on how we as SLPs can effectively partner with RDs to improve patient outcomes. If you're finding this helpful, I'd love it if you shared and subscribed so you won't miss any future content. Now let's talk about some specific ways SLPs can collaborate with RDs. Understand what are our roles. It's always important to understand the roles of our interprofessional colleagues and make sure they understand your role as an SLP. Let's do a brief overview of the RD's roles. The RD communicates their expertise with a nutrition assessment completed on all patients determined to be high risk for malnutrition or dehydration. Patients with dysphagia are of high importance to the RDN because of the potential nutritional impact of dysphagia diets. The standard nutrition assessment includes an estimate of nutritional requirements. Once this is calculated, the RD will then make recommendations to determine if the patient's needs are able to be met with their current diet. Identifying nutritional problems, including problems related to our scope of practice like dysphagia, and referring as indicated. RDs might be the first to identify the need for an SLP consult, creating a plan of care with goals and recommendations around diet plans and special diet modifications to ensure caloric and nutritional needs are met. Incorporating dietary preferences and cultural practices as they relate to maintaining or improving nutritional status. RDs work with patients who are tube-fed and modify enteral and parenteral nutrition as patients progress with oral nutrition when working with the SLP. They recommend the type of tube feed, how much tube feeding and the duration, and they calculate their caloric needs. Main role of the RD is to provide nutritional education related to various medical conditions such as diabetes, cardiac conditions, renal, and GI conditions, just to name a handful. RDs also work with families to educate them on post-discharge care to continue a nutrition regimen. RDs also work with the kitchen to ensure there's proper sanitation, food safety, and sometimes assist with creating the menu. This can be particularly true in the nursing facility. And then, of course, SLPs identify the signs and symptoms of dysphagia, assess and treat dysphagia, incorporate dietary preferences and cultural practices as they relate to food choices during assessment and treatment for dysphagia. Together, SLPs and RDs can respect and advocate for choices related to quality of life, engage in interpersonal collaboration to address patients' dietary needs and determine the need for diet consistency modifications, work with facility administration, caregivers, and patients to facilitate the appropriate use of diet consistency modifications. SLPs and RDs are like bread and butter. Getting to know RDs and frequently communicating with them about my patients in the past has not only saved me time, but improved the quality of care and patient outcomes. In many cases, the RD was my backup voice when I couldn't be there to advocate for my patients who needed additional nutritional support. And sometimes my recommendations held more weight behind them when my interprofessional colleague would support them while bringing in his, her, or their own recommendations that aligned with the patient's dysphagia goals. I've often been able to help patients progress back to a regular diet faster because of the collaboration with the RD. There are some wonderful products and tools that RDs have access to that we just might not be aware of, and we won't know if they'll benefit our patients without consulting the RD first. Collaborate. SLPs and RDNs share the common goals of optimizing patient health and quality of life, says Blake and Gear 2003, and caseloads often overlap with shared patients. Building positive collaborative relationships between SLPs and RDNs does more than just make a happy workplace environment. Research has shown that a positive collaborative relationship between these two fields may result in enhanced clinical practice and patient outcomes. Some ways that SLPs can work together to improve patient outcomes include informal communication through medical records, regular in-person communication regarding patient care, such as instrumental assessment results, patient choices, and preferences, participation in formal rounds or interdisciplinary team meetings, fostering curiosity through in-services, joint quality improvement programs, examples such as the Grazer program and Red Plate study. When behaviors impacting oral intake continue despite the use of compensatory strategies, the Grazer program can be beneficial as it provides opportunities for oral intake versus forcing patients to eat or drink in a traditional manner. The Red Plate study revealed that patients with Alzheimer's disease and patients with advanced dementia improve oral intake with the use of brightly colored dishware. Food preference specifically in the skilled nursing facilities. SLPs can report to RDs patient food preferences, titrating tube feedings based on how they're progressing with the oral diet, educating families towards end of life regarding options for oral nutrition versus alternative means of nutrition. A colleague of mine once worked closely with an RD at a small hospital to make changes around how discussions around PEG tubes were handled with family members of patients with end-stage dementia. My colleague noticed a large number of patients with dementia were getting PEG tubes, despite her recommendations for palliative care consults to discuss comfort options and education around the risks and benefits of PEG tubes, particularly in this population. She teamed up with the RD to provide better education to family members and physicians. This included coming up with a statement and research citation to put in their notes that pointed physicians towards what literature said about PEG tubes and dementia. This eventually led to a surgeon paging my colleague to discuss the literature, because he also noticed a high volume of these patients coming down for PEG tube insertions. They eventually put together a QI plan to educate the primary physicians making these recommendations and incoming residents. Both the SLP and RD had their perspective to provide and offered handouts with questions the medical team could use to guide these difficult discussions. This led to improved outcomes with fewer repeat hospitalizations within 30 days of the patient's discharging. If you'd like to listen in on a conversation with an SLP and RD dedicated to nutrition and swallowing recommendations, specifically when it comes to end-of-life eating decisions, make sure to check out episode 172 of the Swallow Your Pride podcast with Lindsay Parker and her sister Morgan Mendenhall. Want even more resources and support when it comes to collaboration? Check out the MedSLP Collective at www.medslpcollective.com, where we offer journal club discussions, webinars, resources, and a vibrant online community of MedSLPs ready to discuss and support tough clinical questions and professional development issues.